My name is Jess Fuhrman, and I'm one of the current AppERTs this year. My talk today is entitled Moving Inpatient to Outpatient, Best Practices for Outpatient CAR-T Therapy. My content expert is Mike Fallon, and I'd also like to thank Mary Mabley for helping me scope my presentation as well. So learning objectives today, first is to explain CAR-T therapy and the malignancies for which it is indicated, to appraise the financial implications of CAR-T therapy for inpatient versus outpatient administration, and then discuss best practices for implementing outpatient CAR-T therapy. So jumping into that first learning objective of explaining CAR-T therapy, CAR-T therapy, or chimeric antigen receptor T-cell therapy, is a flavor of immunotherapy in which the patient who is undergoing treatment has their own T-cells harvested from themselves. Those patient T-cells are then sent to the lab in order to be engineered to recognize cancer cells. The cancer cell recognition is mediated through antigen recognition on the tumor cells. Additionally, lymphodepletion commonly will precede CAR-T therapy. A few CAR-T therapy indications, primarily for the relapsed and refractory hematologic malignancies, include acute lymphocytic leukemia, or ALL, lymphoma, and multiple myeloma. With lymphoma, there's a few different types, including diffuse large B-cell, follicular lymphoma, and mantle cell lymphoma. An interesting fact is that the first CAR-T therapy was for ALL in pediatric and young adult populations, and this was FDA approved in 2017. Additionally, there are ongoing investigations looking at the utility of CAR-T therapy for additional malignancies. These include solid tumors, as well as some immune diseases such as lupus. This slide highlights the current 6 FDA-approved CAR-T therapy products. Of note with this slide is looking at the cellular target. So there are 4 products that target CD19, as well as 2 products that target BCMA, which is B-cell maturation antigen. So now just a sort of 10,000-foot view of the development and administration of CAR-T therapy. So first, the patient has their T-cells harvested from them. These T-cells then get sent to the lab to have the insertion of the CAR gene. The CAR gene then allows for CAR protein expression. From there, the CAR T-cells are allowed to replicate to grow into the millions. Of note, the entire process can take about 3 to 6 weeks to be ready for infusion to the patient. And then once infusion occurs, the T-cells with that added CAR are now able to bind to cancer cells in order to cause degradation. So now the second objective of appraising the financial implications of CAR-T therapy. So first, the current estimates for CAR-T therapy, the drug cost alone, is anywhere between $373,000 to $475,000. Financial reimbursement, as will be touched on in future slides, is less favorable for inpatient CAR-T therapy. And it's important to note that inpatient reimbursement can still apply for outpatient administration if a patient has to be admitted to the inpatient side of care within 72 hours of infusion, which is usually for side effect reasons. And then just a few other additional considerations for moving out or CAR-T therapy to outpatient is there has been an improved toxicity profile of the newer CAR-T therapy products on the market, as well as institutions have an increased awareness of some of these best practice site requirements that we will further discuss to carry out outpatient CAR-T therapy. So first, looking at the inpatient financial considerations. So in addition to the cost, as mentioned on the last slide, there is the cost associated with the inpatient stay. The study on the slide found an estimated cost of $2,668 per day, and patients who have an inpatient route of CAR T administration were found to have a 17-day median length of stay. Other costs include the staff training needed, as well as costs associated with the REM certification required to have CAR T therapy. And then inpatient financial considerations and the reimbursement process are further complicated by Medicare and Medicaid. So the Centers for Medicare and Medicaid use what's called IPS, the Inpatient Prospective Payment System. And in 2019, the Diagnosis-Related Group, or DRG-16, was used in combination with NTAP, or the New Technology Add-on Payment. And this form of reimbursement sought a 50 to 60% of total drug coverage. And then in 2021, DRG-18 replaced DRG-16. And this change also saw a restructure of the NTAP program. But with all of these changes, the resulting reimbursement was still found to be roughly 50 to 60% of drug coverage. So now flipping to the outpatient reimbursement. For this reimbursement strategy, the acquisition price is used for CAR T outpatient reimbursement in full, in addition to an added Medicare Part B reimbursement markup through the buy and bill system. Of note, there was a cost savings modeling analysis performed in 2021. This paper found an over $30,000 savings with outpatient administration versus inpatient. And it's important to note that this was for overall costs, and this is not including some of those reimbursement differences noted on the previous slides. And then a sub-analysis of this study was looking at just all ancillary costs to CAR T, so all costs except the actual cost of the drug product. And this study found a 40% cost reduction with outpatient administration. Now moving on to a couple trials that have already, from sites who have already been using outpatient administration. So here, Chimera was infused to 68 patients. Roughly 20% were admitted within 72 hours for adverse effects, as well as over 1/3 by day 30. And this just highlights the need for close care centers should a patient need to be escalated to higher levels of care, and that not all outpatient clinics can do this if they don't have close care centers nearby. And the next trial here is the Tresent Trial, which looked at the Breyanzi CAR T product. This had 53 total patients, and a slight improvement with only 3 patients were admitted within 72 hours of the CAR T infusion for adverse effects. So this leaves the question of how can outpatient CAR T therapy be optimized? So moving into my third objective is to discuss some of the best practices for implementing outpatient CAR T therapy. So first, just looking at some key considerations to address. First of all, outpatient CAR T therapy should be multidisciplinary in nature, should engage community providers to bolster a strong transitions of care, have adequate infusion space, and strong policies and procedures. The screenshot here on the right is from UConnect for our site-specific policy, just to really highlight all the work that goes into ensuring this process is as safe for patients as possible. Now just taking a look at some of the stakeholders at play when beginning to plan for outpatient administration. As we can see here on the slide, different players are involved. So jumping a bit more into the coordination of the care team, the picture on the left shows how all members of the team really need to be in sync caring for that CAR T patient, as well as there should be additional considerations most notably thinking about the transitions of care. Patient socioeconomic support also needs to be evaluated. And last but not least, patient preferences. Outpatient CAR T therapy should be a benefit for the patient and not just institution savings. So this slide here shows the overall workflow steps from the first CAR T therapy referral all the way to follow-up monitoring. And the next few slides will highlight some of these steps and the best practices pertaining to those steps. So first, thinking about the clinical and social assessment, it's imperative that the patient have housing proximity close to treatment center, and best practice is less than 2 hours away. Insurance coverage, as we saw in the previous slides, this therapy, regardless of inpatient or outpatient, carries a hefty cost. It's also important that providers have clear documentation. This just helps ensure optimal reimbursement planning can occur. Now looking at the lymphodepletion step, which occurs prior to CAR T therapy, a common regimen is cyclophosphamide plus fludarabine, and pharmacists play an integral role in this step, offering to support to the patient via patient consultation that occurs at their infusion center appointments when receiving not only just the lymphodepletion, but also later the CAR T infusion. So these are just a few snapshots from UConnect, just highlighting the work that pharmacists do and the order sets they are monitoring. On the right is the lymphodepletion for fludarabine and cyclophosphamide. And on the left is just some washout time periods between having lymphodepletion prior to CAR T infusion. Next, looking at the CAR T infusion step itself, there are quite a few REMS requirements, which will be discussed further on the next slide. It's also a best practice to have standard order sets, including pre-medications. Pharmacy and nursing collaboration in the flavor of double verification is a best practice to ensure patient safety, as well as having a detailed infusion timeline, both before beginning the process as well as during. Now looking at the patient follow-up step, one big barrier can be caregiver requirements, and it's a best practice to have a caregiver available from the start of lymphodepletion all the way to day 30 post-infusion. It's also imperative to have a detailed workflow and guidelines, so there's no guesswork playing when a patient is required to be admitted inpatient for severe side effects, as well as what are the detailed monitoring requirements a patient and the caregiver should be doing at home to ensure their safety. So first, looking at the REMS program, there's quite a few requirements. Just to highlight a few, first is just the training program completion, and then keeping detailed records of this completion. The pharmacy-centric aspect of REMS is the need to have 2 tocilizumab doses on hand in the event a patient needs this for any adverse reactions. And this must be immediately available to be given within 2 hours. Now flipping back to the post-CAR T monitoring requirements, first looking through the lens of the patient. So some of these are best practices as well as just general requirements. For one, a patient should not be driving for at least 8 weeks post-CAR T therapy. As I discussed earlier, best practice is a patient to be no more than 2 hours max from the treatment center for 4 weeks minimum. However, most treatment centers ideally want patients to be within 30 minutes and ideally less than an hour. It's also important that patient knows how to and properly documents their pulse ox, temperature, and blood pressure at home. And last but not least, patients should be informed to carry what is called a wallet card, which I have pictured here on the right. This is just an identification card regarding their CAR T therapy status. So if they were to see other providers or go into the ED, they are appropriately triaged given their CAR T therapy. And lastly, looking at the facility for their requirements in aiding patients in monitoring. Healthcare providers should have after-hour availability, and a best practice is a 24/7 hour hotline, so a patient or caregiver can get a hold of a healthcare provider if needed. Telehealth patient trainings are also imperative, and a best practice recommendation is to hold 3 sessions, so a patient feels very comfortable using this service to reach out to their healthcare provider for all of their checkup needs. The facility, if able, should also supply both the patient and caregiver with the monitoring tools needed, as well as to verify correct technique. And last but not least, the facility should detail in completeness to the patient both where and when to seek inpatient care if needed. And as I mentioned, this is typically due to side effects. However, I know the next grill presentation is on CAR T therapy, so you'll have to come back next week to learn a bit more about what those side effects are. And with that, here are my references, and I'm happy to take any questions.